Excellent. So good morning, everyone. It's great to see you again. I know I saw you in transition to clerkship, and I'm looking forward to working with you guys on the psychiatry clerkship. This morning, I want to talk about biopsychosocial assessment. And as we go through this, there are going to be places where I pause and ask you questions. You can put those answers in the chat. That's fine. But I am going to pause until I get answers. So don't tune out. Be prepared to answer questions. So biopsychosocial assessment, I do want to let you guys know that as I put this lecture together, I looked at the Addressing Racism and Bias Task Force and the LGBTQIA plus Affirming Curriculum Task Force. They have checklists. And I thought about those things and put those things together as I developed this lecture. I would love your feedback if you think there's something I could do better at promoting equity in this learning space. And so my email address is elizabeth.greene@usuhs.edu. So if I can improve, please tell me how I can improve. These are our standard disclosures. So obviously, these are my views. They don't reflect the position of the Uniformed Services University or the Department of Defense or the United States government, and I have zero financial relationships that would impact this presentation. So what do I actually want you guys to get out of this? The first thing is I want you to be able to describe the components of the biopsychosocial model. So this is something that we teach specifically during the psychiatry clerkship. You should have been taught it during your neuroscience module as well. But it's something that I hope you'll use in multiple clinical settings. So even though it's a skill that psychiatry teaches, it's not only a psychiatry skill. I also want you guys to be able to think about things like what are precipitating, predisposing, perpetuating, and protective factors, and use those to organize biopsychosocial factors by time to really be able to think in depth about a patient. And then I'd like you to be able to apply the biopsychosocial assessment model to a hypothetical patient. We're going to do that during this talk. And then on your clerkship, you'll do it with patients that you're actually seeing. So what is the biopsychosocial model? This is a model that was proposed by Dr. George Engel in 1977. Dr. Engel is a psychiatrist who's also an internist, so a good multidisciplinary person. I'm family medicine and psychiatry, so I love people who are dual specialty. And at the time that he proposed this model, there was really a lot of division in the field of psychiatry. So some people said, no, psychiatry is medicine and biology. And other people said, no, psychology is it's psychology, it's social factors. And Dr. Engel said, well, goodness, why are we fighting about this? It's both. It's all of it, all the time. It's biopsychosocial. And not only is psychiatry biopsychosocial, all illness, all medicine is biopsychosocial. So everything needs to be considered in the context of the person's biology, their psychology, and their social and cultural environment. So Dr. George Engel created the biopsychosocial model for us. When you're learning a model like this, one of the things I want you to think about is that it's a model, right? And models simplify. So we do a lot of breaking things down when we're learning. We take things apart, we break them into sections because it helps us understand, it helps us grasp the concepts. The reality is you can't separate biology, psychology, and the social environment. These things are intertwined. They impact each other all the time. That's why the arrows in the circle are always going in each direction. But when you're starting to learn, it really helps to try to break them apart and think about how each category might be affecting a particular patient's presentation. And one of the things I really like about this model is that it does encourage you to think about positive factors, right? Things that might be helping or supporting an individual's wellness. It helps you think about a patient in a holistic way. And it also starts to give you ideas about, well, where could I intervene? So ideally, you're not just doing a biopsychosocial assessment just, to please your attending. You're doing it because it'll help you think about, well, what do I need to actually do for this individual to help them move towards wellness? All right, so this is our first little quiz to make sure you guys are still with me. So biopsychosocial model was introduced by who in 1977? You can put the answers in the chat. Oh, there we go. Yay, Logan, thank you. All right. Thank you, Haley. And then, okay, so just to put the answer in there. And then what are at least two strengths of the biopsychosocial model? Yeah, thank you, Paul. Right, it gives you a holistic picture of the patient. What else is a strength? Right, so looking at multiple factors, it's interdisciplinary, right? Looking at complex relationships. And remember that hopefully it also gives you some ideas for intervention points, right? And it helps you think about the patient's strengths and resources. A lot of times medicine's very focused on what's wrong, what's the deficit. Um, but ideally, you should also be looking at what's right with this patient, right? What can help this patient continue to move towards wellness. All right. So those are the strengths that I think about. So let's get specific about biology. I think the biological factors is usually the easiest category for us to think about as physicians because this is what we spend our time on in medical school, right? This is what you guys have just spent the past 18 months learning about. So you might learn a mnemonic like Vindicate to help you think through a differential diagnosis. And when you think about a patient's presentation, hopefully you think through like, is this vascular? Is this infectious? Could this be a neoplasm? Is there something degenerative going on? Is this intoxication? Is it iatrogenic? Is this congenital? Is it autoimmune? Is it traumatic? Or is it something that's endocrine, metabolic, or some kind of a deficiency state, right? So that's the mnemonic I was taught in medical school to kind of help me think through a differential diagnosis. And that's one thing I would want you to always be thinking about, right? So, and you'll get lots of practice on that in every rotation. I hope that you'll be really, really good at differential diagnosis by the time you finish clerkship year. But biology is more than just the underlying illnesses a person might have, right? Biology is also health behaviors. So things like, what is this person's nutrition like? Are they living in a food desert and they have to eat, processed food because that's all that they can actually get access to easily? Do they get enough sleep? I would say that most American adults do not, based on the things that I've read. Are they exercising? Again, I would say most American adults are probably not, based on what I read. So those are health behaviors that can impact a whole host of illness processes. We also could think about genetics, right? And so typically in psychiatry, genetics, we use sort of proxy markers. So things like family history. So if you have the family history of major depressive disorder, right, that suggests that you have the genetics necessary to create major depressive disorder. And we also use the person's own past history of illness as a proxy marker for genetics, right? If you have had an episode of major depressive disorder in the past, clearly you have the genetics necessary to have another episode of major depressive disorder in the future. We're starting in psychiatry to have some actual genetic measurements for some specific illnesses and some kind of interesting stuff going on in terms of looking at underlying genetics for medications. It is not where it needs to be, in my opinion, but it's pretty cool all the same that we're starting to develop that. And still, for most patients, the proxy markers of family history and personal past psychiatric history are going to be the most useful markers. Also, when you think about biological, think about substances and remember that substances include medications. So a lot of times we think about substances and we think about, tobacco and vaping and alcohol and caffeine and things like cannabis, other substance use that's recreational. We forget that doctors prescribe substances all the time, and many of them have psychotropic effects that we never anticipated, right? So think about the medications that a person is taking, as well as substances that they're choosing to ingest, right? And then finally, think about the impact of the physical environment and what they're exposed to. And particularly in the military, it's important to think about this in an operational setting. Is this person breathing in a lot of dust because they're deployed to Iraq, which is what happened when I was deployed. I had dust storms pretty much every week. And how might that be impacting them? Is this person in a very noisy environment? Are they in a very hot environment? There's actually a lot of interesting research going on about pollution and climate change and how that impacts both mental and physical health and wellness, right? So there's a lot of different biological factors that we can think about. And as you think about this, kind of recognize, again, that a lot of these biological factors link to medical illnesses as well as sort of psychological and social dimensions. So diabetes is a classic example of an illness that we think of as a biological illness, but it has very strong links with depression, right? And we don't understand that completely, but we've seen it over and over again, right? So part of what I want you guys to remember is just the connectedness of this. All right, so another quiz. So when we assess the biological factor of genetics, what markers do we look for? Thanks, Jonathan. Exactly. Family history and the person's own past personal psychiatric history. Maybe someday we'll actually have more genetic tests. We're working on it. And then what are some other biological factors besides genetics that you might think about, that I hope that you'll think about? Yeah, substances and medications, absolutely. Sleep, nutrition, physical environment. Yeah, and also remember illnesses, right? So sometimes it's hard to link all these things together, right? There's just kind of a reminder of things that I hope that you guys will be thinking about. All right, so then let's move on to thinking about social and psychological factors. And this is something that I think is a little bit more difficult to get our heads around because this isn't what we're taught to think about all the time. Often this is kind of new in your psychiatry rotation. One thing that really helped me as I was learning this is to realize psychological factors are internal. So they're things that the person thinks or the thing the person feels, their patterns of behavior, their skills the person has, but they're inside the person. Whereas social factors are between the person and something outside the person. So they're external. So psychological, internal, social, external. And that can be a relationship with a person. It can be a relationship with their culture, with the organization, right? And so there are many, 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 many social factors. I've listed quite a few here. Relationships, remember that that's not just intimate partner relationships. That's also relationships with parents, with siblings, with children, with the people you work with your friends, with your pets. All of those are relationships. Social factors also include things like resources. What are your financial resources? What kind of access to medical care do you have? Do you live in a place that is safe, or not? Many people in the world live in a place that's not safe. What kind of education have you had access to? When you think about occupation, you can think about what does this person do? How do they feel about what they do? In the military, specifically asking like what someone does for the military can often be really, really important to understand how their overall picture might impact the military mission, right? Some factors that I think are really important to think about in the social environment are things like racism and other forms of discrimination and oppression. This is something that we're really only starting to reckon with in medicine. We've ignored it for a long time, but there is a lot of evidence that oppression and discrimination has profound biological impact on people as well as social and psychological impact. And finally, I want to draw your attention to abuse as a social factor. So abuse is one of those factors. A lot of times people will put it into psychological, but abuse is something that happens between people, right? Whatever type of abuse it is, it's happening between that person and another individual. And so it is a social factor. Now, abuse is an example of a social factor that has profound psychological and biological implications, right? So again, remember that the circle always has arrows going in all directions. But the abuse itself is a social factor. So then psychological factors, just to kind of differentiate them. Remember that psychological factors are internal. And a lot of times these are the hardest ones to identify because if I say to someone, hey, Dr. Cleves, like, what are your patterns of thoughts and emotions and behaviors? Dr. Cleves might be able to answer me because she's a psychiatrist, but mostly people don't know those things about themselves, right? It's unusual for someone to really have given a lot of thought to what their internal psychological patterns are. So a lot of times we end up sort of inferring or sort of exploring with the patient over time to find out what their psychological patterns are. But some of the factors that you might look for. Beliefs. Beliefs are often some of the easiest psychological factors to identify because they'll come out in what people say, right? So if you're working with somebody and they say, I'm a hard worker and I really believe that if I just keep trying, I'll get this. That's a belief statement, right? They're kind of conveying to you a belief. Like, if I work hard enough, right, I will be able to do this, right? That's actually a very helpful and protective belief. And so again, when you think about biopsychosocial, look for the helpful and protective factors. People might have beliefs about the world. I believe that, most of the time, if you ask people for help, they're happy to help you. That's a belief that I have. It's generally been proven out to be true. So I've had lots of experiences affirming that belief, and that tends to be a helpful belief. You'll often encounter individuals who have less helpful beliefs, right? So a common not so helpful belief that I've seen people experience is, if I don't do everything perfectly, I'm a complete and utter failure. Well, that is a very challenging belief to live with because nobody does everything perfectly. And so people end up feeling pretty bad. So beliefs you'll kind of pick up pretty easily. Patterns, right? You can have patterns of thoughts and emotions and behaviors. And a lot of times these are patterns that we employ without really thinking about them. They're just things that we sort of do by default. And a lot of times they're things that make us feel better. So if you've ever just you've tried out for something and you really wanted something and you didn't get it and you said, whatever, it's not that much, that's not big a deal. I didn't really want it. I didn't have time for that anyway. That's actually a pattern of thought and emotion and behavior. It's called a defense mechanism, right? It's a way to kind of help yourself feel better. You can also have patterns of connection with others. So these often come out of very, very early childhood experiences, like things even before people start to have real memories, like autobiographical memories. But things like, do you believe that your needs will be met if you ask for help? Or do you believe that people are going to ignore your needs? And you'll, again, encounter people with all kinds of underlying patterns. People also have different capabilities or skills. And there are a lot of different kind of psychological skills. I don't know if you guys have ever thought about this, but you guys have a tremendous amount of psychological skills. So one that I know for sure that you guys all have is delay of gratification, right? So that's an important psychological skill that helps you say, I'd really love to play this video game, but instead I'm going to study for my shelf exam because I'd really like to pass, and that's an important goal for me, right? That's delay of gratification, putting something off that you'd like to do in service of a bigger goal. Other kind of important psychological skills, one is frustration tolerance. So when things don't go your way, being able to kind of stay calm and work through the problem without kind of creating more problems around yourself. Being able to understand what other people might be thinking or feeling and empathize with them. That's actually a psychological skill. Right, so there's a lot of different psychological skills. Temperament is a kind of a peculiar psychological factor that actually, again, relates very closely to biology as well. But temperament is sort of the underlying psychological traits that you're born with. So when you guys do pediatrics, I hope that you get to do newborn nursery because, in my opinion, that's one of the most fun parts of pediatrics. And when you're in the newborn nursery, please pay attention to how different the babies are. Like they're hours old. Nothing has really happened to them yet. And yet they're still different because we're all born different, which is kind of cool, really. And those differences, those sort of inborn differences, are what we consider to be temperament. Things like, do you really love to be around a lot of people, or do you prefer being around just a few people? Are you somebody who has a lot of energy, or are you somebody who's a little bit more low key? Are you kind of intense about things, or are you kind of more relaxed about things? All of those are temperament. And there's no bad temperament or wrong temperament, but there can be sometimes a mismatch between someone's temperament and the environment they're in. So their social and their psychological may not be a good match. And that can create some problems. And the last thing to kind of highlight at the bottom, and I put it in its own box because it's so important, is purpose and meaning. And really, purpose and meaning are a subset of beliefs, right? So the work I'm doing is important as a doctor. That's a belief statement. But people who have a sense of purpose and meaning in their life and what they're doing, that's incredibly psychologically protective. So that's something I would encourage you guys to look for in the people that you're working with as patients, because having that sense of purpose and meaning will get people through a lot of really hard things. So, all right, quiz time again. So just to differentiate, psychological factors are blank and social factors are blank. Yeah, great. Thank you, Samuel. Psychological factors are internal, social factors are external. All right. So can you guys list for me at least 3 possible social factors? Great. Relationships, financial resources. Thanks, Cameron. Their job, occupation, education. Absolutely. Thank you guys. All of those things. All right. And a whole lot more, right? So, again, pretty much anything between the person and another person or an organization um, or institution can be a social factor. All right. And so then probably could have guessed this, but list 3 possible psychological factors. Temperament, absolutely. Beliefs, capabilities. Great. Thank you guys. Absolutely. All right. So I think it's great to think about those things, but let's actually try to apply it to a hypothetical individual. So this is not a real patient, but I will tell you that everything that I put in this case is something that I have heard from real patients more than once over the sort of past 20 plus years that I've been doing this. Um, and so let's try to think about biopsychosocial factors for Colonel A. Right. So Colonel A is a 52-year-old Black female surgeon who's going to retire in about a year. And she's coming to see you in your primary care clinic because she's not sleeping well and she's feeling pretty irritable. And so you are a very astute medical student, and somebody comes in saying they're not sleeping well and they're irritable, and you say, I should probably ask a few more questions here because those symptoms can be markers for many, many, many other problems. So you want to do a little bit of digging. So you kind of ask her about herself and her history, and she says she had a really happy childhood. She had no family history of mental illness, although she doesn't really know. Her family doesn't really talk about mental illness. But as far as she's concerned, she had a great childhood. She was an outstanding student. She went to U.S. Military Academy and then medical school at USU. She's always done really, really well. She's loved her career in military medicine. She feels like she's done great things. She does say, kind of as a side note, she's like, sometimes it's been really hard to be the only Black woman in the room. But overall, she's really loved her career. She has had 3 deployments to combat areas and some really significant trauma exposure. She's talking about this. She seems kind of uncomfortable. She gets a little bit teary. She doesn't seem to want to talk about it. But you kind of hear that she, at least more than once, has been under indirect fire, and she's had multiple mass casualty experiences. And, she kind of, again, under her breath says, like, I could have done a better job. Right. So clearly doesn't feel too good about that. 2 years ago, she was diagnosed with prediabetes, and she was given some counseling about nutrition and exercise, but she's very, very busy. And so she really doesn't have time or energy to cook or go to the gym. She's working multiple hours. She kind of grabs, a donut for breakfast and some, not usually anything for lunch, and then fast food on the way home. And she definitely does not have time to go to the gym or to exercise. And she tells you she's really only been sleeping about 4 hours a night most nights, maybe a little bit more on the weekends. when she's not on call, but she's on call a lot because her unit is short on surgeons because some of her other colleagues are deployed. And she says, I'm just exhausted. I'm sad, and I never would kill myself. Like, I know my life has meaning. I know what I do is important, but life's just not much fun anymore. She does have religious faith. She doesn't have time to practice with her spiritual community, but she does say her religious faith helps her. But her spouse and her coworkers have been kind of getting on her. So she's been pretty irritable, pretty snappish with them. And people have been kind of saying like, hey, this is a problem. We don't like this too much. All right. So I want you guys to look at this, and I want you to think about what are some biopsychosocial factors that might be in play here. And just put a couple things in the chat that you can think of, and then we'll flip the slide and look at the things that I came up with. How about some biological factors? Yeah, diabetes, absolutely, right? So we know there's links between diabetes, depression. She's not sleeping enough. That's huge. That's her main complaint, right? All right. How about some social factors? Yeah, her religion is helpful to her, right? Upcoming retirement's a huge one. It's a big deal for people. Sort of both a positive and a negative at the same time for most people, in my experience. And how about some psychological factors? And again, these are things that we might have to infer, but what do you think some of her psychological factors might be? Yeah, so the trauma itself is probably more of a social experience, but she has some beliefs about the trauma, right? That she could have done a better job, that she didn't do well enough, right? So those are the psychological factors. Yeah. So this is what I came up with. Under biological, I put poor sleep, pre-diabetes. Also, sort of separate from that, nutrition concerns, right? So if you're eating a donut for breakfast, not eating lunch, and then eating fast food on the way home from work for dinner, you're probably not getting all the nutrients that you need. And you've probably got a lot of inflammation going on, right? Because you're eating kind of an inflammatory diet. So I'd be concerned about her nutrition. I'd be concerned about her lack of exercise. So we know that exercise is helpful in many, 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 many ways. So not just for diabetes, but it's helpful for, I don't know, pretty much anything you can name. I mean, it lowers cancer risk, it lowers stroke risk, it lowers heart disease risk, it lowers lung disease risk. It also improves your sleep and improves your mood and decreases your anxiety. So if we could get people to exercise, like, probably half of us could find something else to do for work. Although if you can get people to exercise, more power to you. Tell me how you did it. We don't seem to have any clear genetic predispositions because she doesn't seem to have any family history. She hasn't had any personal past history that we heard. And she's got actually a history of pretty good health over her lifetime, right? So she's got some positive factors there. Psychological, right? I should have done better kind of with regards to how she did with mass casualties. I don't think I said this part of the story, but when her coworkers have commented on her irritability, her response has been like, well, you should do your job. Like, some people are just not competent, which, might be true, but probably not helpful in the work setting. We can see that she's got some skills. So she's pretty good at delaying gratification, right? Just to get where she is in her life and her career. We know that she is really good at focusing on her goals and putting off other things. We know that she's got, at least in the past, some really good frustration tolerance. You don't make it to 06 in the military without being able to tolerate a fair amount of frustration. And then she's got beliefs, right? Her life and her work are meaningful. So she's got some protective factors that we can work with. Under social factors, exposure to trauma, right? We don't know what that means for her yet, but we know it's there. Racism and sexism, right? So, when somebody says to you, hey, it's been hard being the only Black woman in the room, they have experienced racism and sexism, in my experience, 100%. So those are important social factors. She's got some personal and occupational relationship stress going on right now, right? Her spouse is annoyed with her. Her coworkers are annoyed with her. pending retirement, you guys picked up on. And again, for a lot of people, that's an exciting time. Like, what's the next chapter in my life? But it's also a huge transition, right? A lot of people who are in the military for 20, 30 years, that's really been what they've known for their adult life. So it's a little bit scary to change. She's got a very high level of education and occupational achievement, and she likes her job. So that's a very positive factor. And she has religious faith. So this is how I would break down her biopsychosocial factors, but we're missing something, right? And there's an important question that we didn't ask in the case history. This is a little bit of guess what I'm thinking, so it's okay if you don't know, but what's a question that we probably should have asked? Maybe related to timing. All right. Why now? So why now is a really powerful question to ask patients. You don't have to be like, well, why now? Because that's kind of aggressive. You need to be a little bit more gentle about it. But it's really important to know, like, what made you make this appointment for today, right? Or what brought you into the emergency room today? And sometimes why now is going to be glaringly obvious. This person had the onset of intense abdominal pain with vomiting and fever 6 hours ago. Right. Pretty obvious why now, because it's acute, right? It's an emergency. But a lot of times people are going to come in and you're going to be like, well, this sounds like it's been going on for a while. What made you come in today? Right. And that gets at some of these time factors. So if we asked Colonel A, like, why now? She'd say, well, I made the appointment a couple weeks ago because I had a pretty big argument with my spouse, and my spouse was mad and said that I needed to get help. And that kind of shook up Colonel A little bit. And kind of right around the same time, Colonel A was so tired that she actually fell asleep at her desk. Like, she had sat down to work on some emails and stuff and woke up about 20 minutes later going, what? And she had never, ever fallen asleep at her desk before. It really kind of scared her, right? So that's why she made the appointment. You also might ask, what was going on when these symptoms started, right? So if you ask her, she said, well, I haven't slept well in a long time, but my sleep got a whole lot worse 6 months ago. And that's when 2 colleagues got deployed. So we ended up going from 1 in 4 call to 1 in 2 call. So she's on call every other week now. She also had a really tough surgical case that had a lot of complications, and there was a lot of extensive review from the hospital. That was very, very stressful, and she did everything right, and there were no problems that were found, but it's really stressful to undergo that kind of review. So that was about 6 months ago. And then that's when she put in her retirement paperwork, right? And so retirement really became more real about 6 months ago. So you can get a lot of information from people about exactly what happened when, and that can help you flesh out like what's really going on here, right? And that adds this idea of the 4 Ps. And this is something that we use in the biopsychosocial assessment just to help us organize some of the factors, right? And it adds this dimension of time. So the 4 Ps that we use at USU, one is predisposing. And think of the predisposing factors as things that are in the more distant past. So temperament is a predisposing factor, something you're born with, right? You've been there your whole life. So think about lifetime factors, think about things that happened years ago, maybe months ago, but things that have been around for quite a while. So predisposing. Precipitating factors are sort of the more recent past, right? Maybe into the present. So, something that happened last week or in the past couple weeks or in the past couple days, even the past couple hours might be your precipitating factors. Your perpetuating factors, those are things that you're like, this is going on with this person right now. And if I don't do something about it, it's going to continue into the future and it's going to keep this person ill, right? So perpetuating factors are going to perpetuate the illness. They're here now. They're going to keep going. You need to do something about them. Protective factors are also things that are present now that you think will hopefully go on into the future that you want to build on or strengthen, or potentially you could help the patient make use of, right? So these are the things that are present now that will go on into the future that can help move this person towards health, right? So your 4 Ps: predisposing, precipitating, perpetuating, protective, and kind of think about them in terms of time. So if we go back to kernel A, right, we can kind of think about her 4 Ps. So I might think about her precipitating factors. What precipitated the worsening of her symptoms? Well, the increased workload, difficult case, pending retirement. What precipitated her making the appointment? Arguing with her spouse, falling asleep at her desk, right? When I think about our predisposing factors, I might think about things like nutrition concerns, lack of exercise, trauma, chronic poor sleep, right? So even before those 6 months ago, she hasn't been sleeping well. And then her self-critical beliefs, right? I should have done better. That can be a really hard belief to live with. Perpetuating problems, ongoing heavy workload, usually not much we can do about that, but something for us to kind of at least note, right? That whatever interventions we come up with are going to have to work around this ongoing heavy workload. Her health problems, right? So if we just try to address her irritability and tiredness without addressing her prediabetes, we're probably not doing her a very good service, right? And her stress and her relationships are perpetuating. And then she's got a lot of protective factors, right? So her social relationships, psychological capabilities, faith, and her sense of purpose are all things that potentially could help her on the road to recovery. So when you put it all together, for me, it looks like this. You don't have to do the colors when you guys write these up, but I do recommend that you think about putting it in a table like this. I find for myself, it's much easier to think about the factors and break them down if I put them into kind of a more visual format. So this is how I would think about kernel A at this moment in time, right? Like what precipitated this, what predisposed her and set her up for this, what do I need to work on, right? So maybe I need to help her with her nutrition. Can we come up with some ways that she could eat healthier even with her intense workload? Can we find some ways for her to fit exercise in to her very busy life, right? Can we think about her critical beliefs, her self-critical beliefs, and are there things that we could do to help her with that? Right. So as we think about, again, biopsychosocial, and we think about it across the dimensions of time, we're also thinking about, so now what? Now what do I do with this information? What are my next steps that take me into treatment planning? And I also want to remind you guys, again, this isn't just a psychiatry skill, right? So I hope that you guys will take this into medicine and surgery and peds and OBGYN, neurology, emergency medicine, everywhere you go. I hope that you'll take this idea that all illness has biological and psychological and social dimensions, right? And all illness is going to have factors that were predisposing and precipitating and perpetuating and protective. And particularly if you have a patient who's not improving, right? You have that patient who has type 1 diabetes, who's being admitted again for DKA. That's a great moment to step back and say, well, what's going on? What is the biopsychosocial perspective, right? Is there a lack of resources that's keeping this person from getting their insulin? Is there a belief in this person that diabetes is a death sentence, so why bother to take care of it, right? So there's often a lot of things going on that if you take the time to step back and find out, can really help you help that person move forward, right? So again, I hope that you will use this skill frequently. I think that is all in terms of, yep, I think that's all in terms of the lecture. Do you guys have questions? All right. Well, if you don't have questions, I think that at this point in time, you can take a short break. And then Dr. Cleves put into the chat the spreadsheet with your assignments. You're supposed to meet in your small groups starting not later than 9 o'clock to review the case and to put together your write-up that you'll talk about in your small groups with your faculty starting at 10.